So hello everyone, I would like to share these results of the IFM2 on 1801 study assessing daratumumab plus ixazomib, lenalidomide and dexamethasone as extended induction and consolidation followed by lenalidomide maintenance in standard risk transplant eligible newly diagnosed multiple myeloma patients. So as you know, quadruplets are the backbone induction therapy before autologous stem cell transplantation since the results of the Cassiopeia trial, and several other groups have evaluated other quadruplets, and especially DARA-RD. That is a very promising combo. In the IFM group, we already showed that the replacement of bortezomib with ixazomib in an all-oral combination with Len-Dex, IRD, has been demonstrated to be safe, convenient, and effective in induction and consolidation before and after transplant. So then we decide to evaluate a quadruplet with DARA plus IRD. And we think that due to the more progressive response kinetics and the very safe profile of ixazomib, we can propose extended induction and consolidation in standard risk newly diagnosed multiple myeloma patients. So here is the study design. The patients are enrolled if FISH screening confirms the absence of translocation 414, translocation 1415, and the absence of deletion 17p. They receive 6 cycles of ERD DARA in induction with IXA at 3 mg per dose and use biweekly, day 1, day 4, day 8, day 11. Lenalidomide for 15 days per cycles. Then the mobilization was performed after cyclophosphamide. Then patients receive high melphalan course plus transplant. And the consolidation consisted on 4 cycles with IXA at 4 mg, but weekly. And the cycles were 28-day cycles in consolidation. All the patients who completed consolidation receive a maintenance with lenalidomide at 10 mg during 2 years or until progression. So this is the patient's characteristics. 45 patients were included. The median age was 57 years. You can see the distribution of ISS stage, and as inclusion criteria, there is no high cytogenetic risk in this study. And you can see the clinical feature. The primary endpoint was the MRD negativity rate before maintenance after consolidation, and the MRD negativity was assessed using NGS method at a sensitivity threshold up to 10 to -6. 38 patients were evaluable for this primary endpoint, and the MRD negativity rate was at 39.5% at 10 to -6. We also evaluated the MRD negativity rate at 10 to 5 threshold because it is a IMWG threshold to allow indirect comparison. We also assess the MRD kinetics, and as you can see, at the more sensitive level, at 10 to -6, the MRD negativity is only at 6% after induction and increase after transplant and after consolidation. When we look at the outcome in terms of PFS, the PFS is very good. And as you can see, at 2 years follow-up, only 3 patients did progress, and there is no death in this study. So there is a short follow-up for now, but the outcome is good. And the safety is very good also. There is adverse events, hematologic adverse events, neutropenia and thrombocytopenia, but only in 31% and 11% respectively. Some respiratory tract infection, but only 8% of grade 3 and 4. There is no severe peripheral sensory neuropathy, and there is some gastrointestinal disorders with ICSA and LEN, but no severe adverse events. Only 6% of grade 3 and 4. Some rash, but only grade 1, 2, and no death, no toxic death, and only one SPM, one myelodysplastic syndrome for one patient. So in conclusion, we can say that JAVA IRD has extended induction prior to and as consolidation following transplant was safe, and allows gradually deepening responses in standard risk newly diagnosed multiple myeloma patients. We report in this study 39.5% of patients with MRD negativity at 10⁻⁶ after consolidation, a 2-year PFS rate at 93.3%, and a 2-year OS at 100%. However, these MRD negativity rates are lower, and especially at the post-induction assessment, than those obtained with DARA VTD or DARA KRD, which should be preferred in MRD-adapted strategies in a view to cure patients in transplant setting. However, due to its very safe profile, JAVA IRD might be used for standard risk myeloma patients with neurological and/or cardiovascular comorbidities. I thank you for your attention.